So, hello, my name's Toby Sanders. I'm the Chief Officer of West Leicestershire Clinical Commissioning Group. I'm the Chair of our System Resilience Group, and I'm also the Chair of our Emergency Care Network across East Midlands. Tremendous to be here with you today. So, what we're not going to do is talk you through our vision and our model, because I suspect that's going to become rather familiar as we go through the course of the day. What we're going to concentrate on are the things that we are going to practically implement and do that will make a difference, and we think make our offer one that the programme needs within it. Ours is a SRG level application. We serve a large 1.1 million population, which includes Leicester City, fairly dense, urban, deprived, very diverse community, right through into parts of Leicestershire County and Rutland County as well. And at the heart of our System Resilience Group, we have a large acute provider in the University Hospitals of Leicester, running the busiest A&E department outside of London. Roll back 18 months, we were in a position as a system where we were consistently amongst the poorest performing systems in the country, both in terms of standards, quality and experience for our patients. Over the last 18 months we have massively turned that around. We've invested hugely in new services, a new older people's unit, new clinical response services in the community, a new mental health crisis house for example. As a result of our efforts pulling together as a system over the last year, we have become the third most improved system nationally in terms of A&E performance. We have reduced delayed transfers of care from 5.5% to 1.5%. We have one of the highest levels of ambulance non-conveyance in the country. But we have a massive way that we still want to go, and that's why we're up for this, because we're ambitious, we've really got some momentum behind us, and we've got a clear plan of what we want to achieve. We've got three areas in terms of our unique selling point that we want to draw out and emphasise for you today. The first of them is around new integrated and extended community response in and out of hours. And Professor Azar Faruqi, who is a local GP and chair of Leicester City Clinical Commissioning Group, is going to walk us through that briefly.
Okay, thanks very much, Toby. Just before I talk about community and out of hospital care, I just want to reiterate one of the strengths of our bid is a huge clinical engagement. So clinicians not only have helped devise it, but they're going to help deliver what we propose. In terms of our community and out of hospital component, we really have a massive window of opportunity in Leicestershire. We've got out of hours services, walk-in centres, urgent care centres, 111, 7-day GP services, and they are all up for reprocurement in the next 6 to 8 months. So that really is a fantastic opportunity for us to start thinking about how we can integrate and coordinate those services, because in common to many areas, currently they are very fragmented and don't do patients good service. So that is a real window of opportunity for us. The other thing we've got is we've got GP federations developed in our patch, and they are advanced and they have almost universal coverage, and they are really up for this. They are really keen to get engaged with this and are committed to senior clinicians now becoming involved in out of hours and urgent care services. We've got the Prime Minister's Challenge Fund as well, which is not only looking at hub-based 7-day GP services, but also is looking at online services as well. And in that programme, we've got a 60% plus commitment for the clinical services to be delivered by senior clinicians, i.e. GP partners, as well as pharmacists. And also we are being innovative in terms of addressing some of the workforce issues, in that we've got a physician assistant programme as well, which is shortly going to be launched in our area. So those are all fantastic opportunities for us in terms of looking at how we can coordinate and integrate out of our services, because the inflow element of this is really important. My colleagues are going to talk about what happens in hospital and front door, but unless we get community services right, and unless we work more collaboratively with our better care funds, and that's the other advantage we have locally, we have well developed better care funds with community response teams and so on, we're not going to really make a difference. So I think the out of hours community element of this programme is really important, and I hope you agree that we are now looking at really improving that significantly in the near future.
Thank you, Azar. So, secondly, the second big USP within our scheme is around the redesign of our acute front door at the Leicester Royal Infirmary site, linked to the long-term redevelopment of that entire site. And I'm pleased to say that we've got Dr. Jay Banerjee, who's the Associate Medical Director for Quality Improvement at Leicester Hospitals and the ED Consultant.
So I was involved in the Religious Department last night, and guess what we had? A lot of frail older people, sick children, people with mental health problems and substance abuse. If I were to quote shamelessly, I said the moral test of an urgent and emergency care system is how we provide care for those at the dawn of life, those at the twilight of life, and those in the shadows of life. One of the key things about building an effective system is supporting an integrated workforce that has got the right structures and processes to enable them to deliver the care that they're trained to deliver. We already have a lot of advantages in Leicester. We've got a fantastic children's emergency department, children's ED qualified people. We have got a good geriatric unit. We've got an emergency frailty unit. Over the last 5 years, we've got an integrated workforce training emergency physicians and how to care for older people, emergency physicians how to care for children, and we also have now got GPs coming and working to develop further expertise in children and in the care of older people. We have got access to primary care coordinators, access to community services. What we are really trying to do is develop more of an integrated workforce with information, digital media links, as well as within one build to enable to deliver all of this in our new £46 million build, which is coming into force hopefully end of next year, which will also have the first geriatric design principles of any emergency build in the country.
Excellent, Jay, great. I'm going to move us on. Last area in terms of our USP is the work we're going to be doing around alliance contracting, bringing together a whole host of network providers. John Adler, Chief Executive of Leicester Hospitals.
Very, very quickly. Essentially, we all know the incentives in the system financially don't really work. We already have experience of an alliance contract for elective care. We have a risk-sharing contract for emergency care this year. We want to develop that into something where we have clearly aligned incentives across the whole system to give the right treatment in the right places at the right times. Simple as that.
Excellent. Thank you, guys.
Thanks very much. Time now for questions. If you could put your hands up, please. Thanks.
Hello, my name's Bobby Pritap. I work at the NHS England Crisis Care Programme. You mentioned about payment models and contracting. I just wondered if you've got any plans to integrate mental health into your payment model, whether it be 24/7 liaison services or 24/7 crisis response. It's good that you've got out of hours because that's when most mental health crises seem to happen.
Yep, I'll start us off on that. Yep, absolutely. We've got crisis response services within our patch. We've got liaison psychiatry within our emergency department. What we're looking to do through the alliance contracting approach, and we've trialled this over the last year in plan care, we've successfully set up one of the largest alliance contracts in the country in the last 18 months. We want to take that model and try and see if we can replicate it around urgent care. Because what we've seen it do for us is to align some of the incentives and behaviours into that best for project kind of approach, where all partners are working together around that same set of outcome measures, rather than the time that we all know is practically pulling in slightly different directions. Leicester Partnership Trust run our local mental health services. They're absolutely up for engaging with this. Sheer numbers today meant they couldn't be with us on the stage.
We've got a question here.
So, aside from the fact you're looking like a fantastic boy band, what is your unique selling point? What is your unique selling point?
Stolen on microphone. We basically have multiple selling points, which are essentially the ones that we've emphasised. So really the three things that Toby said. It's the emphasis on stopping people becoming hospital in the first place, the new models of care beyond the ED. It's a completely integrated approach, particularly in the specialty integration, which Jay was talking about in the ED. Just to mention that the ED isn't at £46 million. You obviously get more than an emergency department. It's called the emergency floor development because it's integrating all the assessment units as well to get seamless flow. At the moment, there's 4 floors apart at the Leicester Royal Infirmary. So we have the whole thing is very strong conceptually, which is why I think it's been funded nationally. And the third element is this completely new approach, as far as we're aware, to contracting for emergency care.
Hi, Deborah Al-Said. I'm delighted that you've got the words digital information and media in your bid. Could you just unpack that a little bit and just explain a little bit more about what you're proposing to do with digital media?
Sure, I'll have the first point of that. We know from our patients, because we've been working really closely with Health Watch locally, they spent a week in Leicester Royal Infirmary recently, gave us some massively valuable feedback. The patients often say to us, they simply don't know how to navigate their way around the system, they don't know what access times, wait times look like in different parts of the system and what service is appropriate. So we want to link the system modelling work we're going to do around predictive demand and activity, and also real capacity in different areas, into using social media to be able to communicate to patients so that people, both patients and staff, can see in more real time what's happening across the system. We also want to use the digital side of things in terms of resource deployment within provider organisations. At the moment, EMAS, the ambulance service locally, is about the only provider we have who has real-time dynamic deployment of resources linked into what's happening around predictive activity, and we think we can use information systems to do that much better.
Hello, my name is Anne Joshua. I'm the pharmacy lead with NHS England for NHS 111. You mentioned about having pharmacists working in your urgent care centre, but I'm very interested in the community aspects of this in terms of the role of the community pharmacist and how you see that being part of your network.
Well, I think one of the big opportunities we've got now in terms of some of the workforce issues is that the NHS is relatively fortunate that we've got a surplus of pharmacists. And we really have plans to help those deliver some of the workforce issues that we've got, both in hours and out of hours. So, for example, we are now working very closely with our community pharmacists in bringing them into GP surgeries to help deal with a lot of the issues that normally GPs would deal with. And already we're finding in a lot of practices that is taking a huge workload off for GPs. But in addition to that, in terms of our Prime Minister's Challenge Fund, we are using pharmacists in our online service to give advice, and also in terms of consultations and support for the GPs, physician assistants and practice nurses who run the out-of-hours services.
Thank you. Jacqueline Winstanley, Chair for People with Hidden and Fluctuating Conditions in the UK, and also he was a patient rep. I noticed you were talking about a single point of access, and in terms of health inequalities and reducing health inequalities, could you tell me a little bit more about how you're going to ensure there's alternative formats for patients in this regard?
Hello, I'm JP Nolan, Head of Nursing at the Royal College of Nursing. So lots of exciting capacity available across your patch. I was just wondering how accessible that is to people working in the different component parts. So if I'm a nurse working in your single point of access or your ambulatory emergency care or your 111, do I have access to that capacity across the piece to move the person I'm consulting with into a hot clinic or into another contact point?
I mean, currently, yes, we do. From within the emergency department, we can actually access all those services 24/7. And over the last 6 months, it's actually increased significantly. So, for example, in the middle of the night, we can actually send an older person who lives alone at home with a head injury, because we've got a night nurse service to be able to go out and actually sit with the patient overnight. And we've got access to medications, and instant reviews can be arranged using full social services, physiotherapy, occupational therapy, and district nurse the following morning in a person who's discharged the night before from the emergency department.
In terms of the first question, in terms of single point of access and particularly the diversity in accessing information, like I'm sure many people in the room, we've kind of got multiple single points of access still going on. We've managed to consolidate a lot of that within health, but between health and adult social care in particular, we're still running different services. So what we're looking to do for this piece of work is to integrate those two services and then get them much more connected to NHS 111. Because of the very diverse population we have in Leicester City in particular, we've got a huge amount of experience in terms of access, in terms of language, in terms of different formats for communicating and sharing information with patients and the public. So we're going to build on that track record.
Many thanks.
Just to add to that finally, is that certainly with our very diverse population in the city, we make huge amount of use of voluntary groups and lay groups, and working with them to help people to access the services as well. So in terms of simple point of access, we also work with our voluntary sector to make sure that they can help navigate patients through as well.
Thank you very much to Leicestershire and Rutland.